You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Oh, hello, everyone. I'm Yi Zhang. I'm the host of the Just Medicine podcast. And today we have a really amazing guest, Dr. Tribesty Nguyen, who is a resident physician with over 10 years of experience in social justice, health equity, health policy, and political advocacy, particularly with TUS LGBTQ plus refugee and racialized communities. He has worked with numerous government agencies and community organizations in consultant, academic, and leadership positions, including as the chair for the Health Initiative for Men, co-chair for the City of Vancouver's TUS LGBTQ plus Advisory Council, and policy analyst for the BC Ministry of Health. So thank you so much, Tribesty, for being with us today. And we'll kind of just jump in. Today's podcast will be focusing on kind of the challenges that GBTQ men face in healthcare today. We'll talk a little bit about taking a sexual history, access to PEP as well as PrEP, and then some other issues that we might not discuss as much for GBTQ men. So it's a lot to fit into one podcast. But I think, we acknowledge that these issues are really broad, and we just want to give a little bit of a primer to the medical learners who are listening to our podcast. So just starting off, Tribesty, what are some challenges that GBTQ men face in navigating healthcare just in general?
Yeah, of course. And just, I guess, before I jump into things, thank you for having me tonight and then the opportunity to chat a little bit about this, I think, very important topic. And then also, I guess, just before I jump into answering the question, just wanted to make a comment about GBQ. It's for folks who have not heard that terminology before. G stands for gay. B stands for bi or bisexual, Q stands for queer. And so I believe we are talking about GBTQ men. But I just wanted to kind of critique that terminology also, because I think it excludes quite a lot of people who have similar experiences as the group we're talking about. So, for example, I think, in this terminology, we're not including trans men, we're not including non-binary folks. And so I think there's a lot of people that we're still kind of excluding when we're using this term. Okay. And then I guess just to get to your question in terms of what are some challenges that GBTQ men face in navigating healthcare, I think there's lots of issues. And I think maybe one way to think about it is to think about different levels of challenges. So I think there are challenges associated with the person themselves, like the patient themselves. And then there's challenges when that person interfaces with their care provider or the health system. And then I think all of this is informed by larger structural issues and challenges, systemic challenges. And so when we think of that first level, maybe the micro level, the individual level, the personal level, I think GBTQ men, GBTQ folks face like challenges with stigma, right? Face challenges with how they may identify, how they are maybe out or not out. And because of that, I think it informs how that person, the individual, interfaces with the healthcare system, right? So folks who are not out, for example, might not be comfortable in accessing, like queer specific healthcare, right? Because they're not out, they're not open about that. And so those are maybe some of the individual or personal level challenges. But then there's also challenges with the healthcare provider, right, or the healthcare system. So, for example, I think there's healthcare providers who, unfortunately, are not very culturally competent. And so they might stigmatize GBTQ folks. They might discriminate against GBQ folks. And so if your healthcare provider is like that, it makes it very hard for you to, receive care from them in a very good way. And then there's also, I think, challenges with a lot of the healthcare system and our healthcare providers just not having the knowledge. Like I think a lot of physicians, nurses, clinicians, unfortunately, just haven't had the training. They don't know a lot about, for example, trans care issues. They don't know a lot about the specific health issues that GBQ men and GBQ folks experience, right? They don't know about sexual health. It's not something that it, I find is like very standardized in our clinical training. So I think there are knowledge gaps, right? Just on the healthcare provider side. And then obviously when we go up a level to like the structural level or systemic level, there are issues of oppression that kind of inform everything, right? Informs our personal experiences, informs how the healthcare system's set up, informs why that healthcare provider did not receive the training, right? And those are like pretty big issues. There are things like heterosexism, there are things like cissexism, and there are things like a lack of research, right, into this population. And so I think there are many, many different challenges that this population faces. I think we can think about them, from the individual level all the way up to the structural level. And I think that they're all related to each other too, right? Each one of those things kind of inform each other and compound the issues that this population experiences.
Yeah, thank you so much. Thanks for giving that really, I think, informative and insightful answer. Because I think, a lot of times when we're thinking about kind of vulnerable populations, it's just that, okay, yes, like I think medical school, they kind of teach, okay, there's these inequities that exist. But I think we're not really taught to think about like it on this deeper level and think about, all the kind of players that are affecting, the care that our patients receive. So I think thinking on a more systemic level, I think that's kind of like the approach and the mindset set that we really need to we need to start like adopting more. So I really appreciate the insight there.
Yeah, I find just, I guess maybe just to comment on what you mentioned. Yeah, I think in medical school and clinical training, in healthcare training, we're often given all these statistics about like, oh, this is the disparity that this population faces, right? But that disparity didn't come out of nowhere, right? It was created because we have an unequal system. We have a very oppressive system, right? That has from the top all the way down to the bottom, it's created this disparity, right? And so it's I think it's can be harmful if we only talk about the statistic without critically thinking about what is the root cause, right? What's causing these statistics?
Yeah, yeah, absolutely. And I'm really grateful that we're having this conversation, to educate medical learners because I think it's interesting how I think like for myself as well, I honestly have a lot of I think unfamiliarity with this patient population. And then as a result, I think in general, because in medical education, we don't really have many lectures or many opportunities to kind of practice these skills. Like I think to this day, I'm now at the end of my fourth year in medical school, and I think I've, been able to learn about heart failure, and now I'm like super comfortable asking about all these other common health presentations. But I think to be really honest, like I still feel really out of my comfort zone when taking a sexual history. um, and then I think especially with respect to GBQ folks, it's just that I just haven't had the exposure, unfortunately. And I think medical school hasn't really been effective in filling that gap. So kind of wanted to pivot towards that a little bit because we just aren't taught about that. So what are some, basics we should really ensure we cover when we're taking a sexual history with this population?
hmm So I think most people, including GBTQ men, um, are not used to talking about sex. And they're not used to talking about, and particularly with a stranger, right, or with a clinician. And so I think maybe, first of all, just acknowledging that these are like stigmatized conversations, right? These are conversations that this population has felt judgment about for a very long time. And so maybe just recognizing that maybe not everyone is comfortable talking about this. And so I think it's important to approach it with that care, right? To make sure that you get informed consent when you're talking about this or starting to have this conversation, right? Like, and make sure that we normalize these types of conversations as well within a clinical setting. So, you can always open by saying, "Hey, like, I'd love to talk to you a little bit about your sexual history. It's important for me as your physician or clinician, your care provider, to know, your full history so that I can, give you the best care possible. These are questions I ask of all of my patients, right? And I'm going to ask you about your sexual practices and identity and preferences and always get informed consent. Like, is it okay that we have this conversation? So yeah, set it up, right? Set up the conversation so that it feels comfortable, keeping in mind that this population has received a lot of discrimination and stigma because of sex. And then I think the other thing also is to not make assumptions right off the bat. I mean, if you, for example, are a family physician in a longitudinal practice, maybe you know your patient already, but if this is the first time that you're meeting this patient, don't make any assumptions about their sexual identity, about their gender identity, what kind of practices or preferences they have. So keep everything open. And I would suggest trying to keep the terminology neutral, like gender neutral. So, and also just clarifying like the language that the patient would like to use. So sometimes when we refer to genitals, certain folks don't like it to be called certain things. And so maybe asking that first, like, hey, like how, when we think of genitals, what language would you like to use? What do you like to refer things to? Right? You can always say like, I generally use medical terminology, but I want to learn what you like to use, what language you like to use when you refer to this body part or that body part, right? So clarify that language before you start to use it. And then in terms of like the components of a sexual history itself, I don't think that there's any like one correct way to do it. I think, use whatever makes you feel most comfortable, use whatever works for you. There is like a general sexual history framework from the CDC, the Center for Disease Control in the United States. It's called the 5 Ps. I believe it is, and don't quote me on this, so everybody should Google this, but I believe it's partners, practices, protection from STIs, past history of STIs, and pregnancy, I think are the 5 Ps. But then if you Google around, like there's many different organizations and communities that have added on to this framework. So again, just, Google, do a search out there and use whatever framework for a sexual history that works best. But the 5 Ps are kind of like the basics, I think, for a sexual history. So in terms of like you want to ask about partners, right? You want to ask about who their partners usually are. If it's one partner, do they have more than one partner? Ask everything that you can about the patient's sexual partners. And then the other second P is practices. So ask about what their sexual activity is, right? Or what their practices are. What type of sex do you like to have? Or do you usually have? Do you use toys when you have sex, right? Like you can ask a lot of things just to get a very clear understanding of the actual sex activity that takes place for the patient. And then make sure to ask about protection, which is the third P. So, and I think what we mean is protection from STIs, sexually transmitted infections. So, when you have sex, do you use condoms or barriers, right? What do you use to protect yourself from STIs? And then also ask about the past history of STIs. So, have you had any STIs in the past? Have you been diagnosed with syphilis or gonorrhea, blah, 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 right? Ask about past history. And then the fifth P from the CDC is pregnancy. So, have you thought about pregnancy? When you have sex, are you intending to get pregnant? Have you thought about, saving your eggs or what, asking around pregnancy and pregnancy intention. So those are the five basic Ps. And then you can add on anything else that you think is important. I guess the other thing is I think so a sexual history isn't always required, right? I remember in medical school when I was learning how to take a history, I was like, oh, I need to take a full history with every patient that I see so that I get a full understanding of who they are, right? But I just want to recognize that a sexual history is not always the appropriate thing to be asking, right? In every clinical scenario. I think when you're asking these questions, there should be a reason why you're asking it.
Yeah. Yeah, thanks for sharing that. I think all of what you said is just so important in terms of navigating care for this population, because I do think that, we have a tendency in medicine to kind of kind of go into a patient space, right? If they're hospitalized, kind of we can get into this rhythm where it feels really normal for us to be asking all these possibly invasive questions of patients, but yeah, they could be at, a very vulnerable point in their life. And I think it is really important to be cognizant of that and to, come from this trauma-informed lens of trying to build rapport and make the patient feel comfortable. And yeah, it's really important that we acknowledge that. I think for this population in particular, because of their, experiences with healthcare in general, they might not be at a point in, their life where they feel comfortable talking about this. And I think if, like you said, if it's not necessary, right, perhaps we defer that conversation, or at least we should really take the care to make it as comfortable and as safe of an experience as possible for patients. So I think, yeah, thank you. Thank you so much for sharing that, because I think ultimately building rapport should be something that we really prioritize with any patient. So thank you. I think kind of, I guess, shifting the conversation a little bit to another topic that we don't really get much education on in a school. I think, a lot of us have heard the acronyms like PEP and PrEP. And I think from my very, very limited understanding, I know that it is for preventing HIV, either post-exposure or pre-exposure. But I don't really know the kind of nuances of that. So kind of, can you share your insights on that?
Yeah. So yeah, PEP or PEP is the acronym. It stands for post-exposure prophylaxis. And then PrEP, PrEP, stands for pre-exposure prophylaxis. And so actually PEP and PrEP are they're not specific to HIV. There's many actually other communicable diseases and infectious diseases that we would use PEP for or PrEP for. And so it's not HIV specific. But in terms of HIV, or I guess like in general, the principle behind PEP is you would take some sort of medication or some sort of therapeutic modality that is after exposure. So after you've been exposed to the infectious agent or whatever, you would take this medication or this therapy to prevent yourself from getting the infection. That's after exposure. And then PrEP is the one that you take before the exposure. So you would take the medication or the therapy or whatever before you get exposed so that you prevent yourself from getting the infection. So that's essentially what PEP and PrEP are. And then in the context of HIV, they are antiretrovirals. So they're medications, that you take either after you've been exposed to something that might be infectious, or something that you take before you know you're going to be exposed. So for example, you're having, for example, unprotected sex with a lot of different people, or maybe, you are in a relationship and your partner is someone who's living with HIV. So it's medication you take before that exposure, so to prevent the infection.
Thank you for that explanation. I think, it's interesting because I think somehow kind of in conversations, we mostly talk about it in the context of HIV transmission, but it is important to have that awareness that it is also for other infectious diseases as well. And I think it's interesting because, I have had patients kind of come in to either the ER or like a walk-in clinic, and I found that historically kind of there is this gap in knowledge in terms of how patients can like access it, and what options are available. So can you kind of speak to that a little bit as well?
Yeah, totally. So, a lot of folks don't know that in BC, HIV services, like PEP and PrEP, are a provincial program. So it's all done out of the Center for Excellence at St. Paul's Hospital, and so that's actually where the medications are administered from, you can say. The pharmacy at the hospital, there's a special pharmacy at the hospital, and they deal with dispensing these all over the province. So it's centralized in BC. In terms of accessing PEP, which is post-exposure prophylaxis, it's usually done through either a physician, like your family doctor, or from the emergency department, like you've mentioned. I believe most emergency departments in BC stock PEP. And the way that it works in BC, which is very similar, I believe, to other jurisdictions, is just say, for example, you had sex last night with someone who told you after you had sex that they are someone living with HIV and they're not on medications, and you were like the receptive anal sex partner and it was unprotected. So let's say this is the clinical scenario and you're like, oh, I didn't know that, and I want to mitigate my risk of getting that infection as much as possible. You can go to the emergency department, any emergency department, and you can tell them this. And they will do a whole assessment, or like a risk assessment, in terms of, how high the risk is of infection, because not all exposures are where not all exposures will be an indication for PEP, because there's some like, for example, if you're exposed to saliva from someone, that's like no risk, and so you don't get PEP for that, right? But if the risk is high enough, the emergency department will typically give you like a starter pack of PEP, which are some antiretrovirals that you take, and I believe the starter pack is 5 days long, a 5-day long supply. And then after that, there's supposed to be a request or a consult with the pharmacy department at St. Paul's Hospital. It's usually done like you would after you start taking the starter pack, you might talk to your family doctor, then your family doctor would talk to St. Paul's Hospital, and then they will do another risk assessment, and then they will decide whether to prescribe like the full course of PEP, which is a 28-day course. And so sometimes after you start the 5-day starter pack, sometimes the pharmacy might say, oh, like this is actually a low risk exposure. And so, a full course of PEP is not indicated. And so they might actually not prescribe the rest of the course of antiretrovirals. And then, in other cases where they assess that the risk is high enough, then they'll dispense the full 28 days. So that's what PEP is. And that's essentially how you access it. PrEP, on the other hand, is accessed through family physicians, like sexual health clinics. There's an STI clinic in Vancouver that the BC CDC runs. So, and then there's nonprofit clinics that are also PrEP prescribers. So many different clinics, family physicians, specialists will prescribe PrEP. And basically how it works is there is like a risk assessment that's done to make sure that you're eligible for PrEP, to make sense that, hey, the patient is at a higher risk of like HIV exposure. And so, they're eligible to get this prescription, and essentially you get a prescription of antiretrovirals that you either take every day, or there's like a sort of like a PRN dosing where you take it when you're going to have sex, and you take it before you have sex and then after you have sex. But yeah, there's like different ways of dosing it. But the idea is to mitigate the risk of some folks who are at a higher risk of infection to prevent their infection. And so you enroll into the PrEP program, and then you'll get the medications again from St. Paul's Hospital. You'll either go to the hospital, or the hospital will send it out to your pharmacy or your family doctor or whoever, where you can go pick it up. And then there's regular monitoring. So you have to do like regular STI testing. And then every so often, you go back for an assessment, your prescription gets renewed, then you get more medication, and you stay in the program. And so that's how the PrEP program essentially works in BC.
Mm-hmm. Yeah, that was super informative. I think like I didn't really know that, I guess there was, sort of this official organization through, I think, yeah, the BC CDC that like kind of offers this, and then through St. Paul's. I'm just curious to hear, so like hypothetically speaking, if you are, just like a family doctor working in your own clinic, or if you're working in a walk-in clinic, to help patients access these services, like, do you actually have to make a referral to like a sexual health clinic, or is it more, patient self-referral? You kind of give them the resource, and then they can kind of like walk in, or like is access quite difficult? What does that look like for patients?
Yeah, that's actually a really great question. And I don't know off the top of my head how family physicians do it. I actually can't remember off the top of my head. I wonder, and again, I might be completely wrong here, but I wonder if family physicians have to enroll maybe into the PrEP program as prescribers. I'm not 100% sure. I'm just kind of like making a wild guess right now. And then there are programs out there that you can self-refer to. So for example, the STI clinic that runs out of the BC CDC, you can just walk in there, and they do like virtual appointments as well. Or there's other clinics. So for example, the HIM clinic, the Health Initiative for Men, you can also call them up and then, self-refer and say you're interested in PrEP. And then they will also schedule you in as well. And so if family physicians are not a part of the program, I guess I'm unsure about that, but if they can't prescribe or they want to refer on, like these are clinics that can help with that.
Mhm. Okay, that's really good to know. That's super helpful, I think, for our listeners to know that the sexual health clinics are available. Um, are they kind of only in the Lower Mainland, or are they kind of like spread out across the province as well?
Yeah, that's another great question. So there's a couple of different organizations that run sexual health clinics. So for example, Options for Sexual Health, and they run clinics that are kind of dispersed around the province. And then there's regionally kind of specific clinics. So for example, on the island, there's Island Sexual Health, and they run like a clinic in Victoria. The HIM clinic, the Health Initiative for Men clinic, is currently only running out of Vancouver, but and that's because just because of capacity after the pandemic. But they used to run clinics all over the Lower Mainland, and so yeah, there's many options for clinics around the province. But I also know that there are these like private companies. I don't know if they're companies or like private organizations that also offer PrEP prescriptions. So, for example, there's one called Freddie, I think, or Go Freddie, where you can get a PrEP prescription from as well. But I don't know how they work fully. I believe that they are a private organization of some sort.
Mm. Okay, that's good to know that I think at the very least, like there are options, I think, for people who live outside of the Lower Mainland. Because I think it can be, somewhat difficult sometimes for GBQ folks to have access to all these different health services, especially when they're in a more rural setting, or if they don't, yeah, live in the Lower Mainland. I found that especially kind of in my context, I did most of my training in Kelowna, and I think sometimes it can be difficult for patients to go to the appropriate services. So it's good to know that there are like more options becoming available.
Yeah,
Yeah.
I think like queer and trans health is often community led and often community created. And so oftentimes these services are provided by nonprofit organizations. And so a lot of these clinics are like, dispersed around the province and sometimes, don't talk to each other in the sense that like we have a public healthcare system that's like, most of the time everybody talks to each other. Services are standardized in some way, right? And so I think that's one probably one factor why it can be confusing where you can go to access PrEP because there are so many different providers that kind of all independently run.
Mm.
But yeah, I would say if anybody out there is interested in PrEP, like Google is your friend because you can Google like PrEP, BC or PrEP, where the city that you're living in, and there will be information that will pop up, right? Like if it's not a community-based organization, oftentimes it's the health authority that's providing that information, and so yeah, Google is your friend.
Yeah. Okay. That's, yeah, good to know at least that there are just these different options out there. I did want to shift the conversation a little bit because I think, when we talk about kind of care for GBQ folks, I think there is almost this excessive focus at times on sexual health. So, yeah, what are some other health and wellness issues for this population?
Yeah, yeah, totally. And I think sexual health is the big one, right? Like I think sexual health and the HIV epidemic is really kind of what's the word I'm looking for? Like not bolstered, but like gave like the rush of resources and like program development that came out, with for GBQ men's health. And so I guess what I'm trying to say is like sexual health is like at the core of it or at the beginning of it or at the was the driver of this as a field of healthcare. But yeah, you're right. There are so many other areas of health and wellness that are very specific to GBQ men. And one of them, for example, is mental health. I think, we talked a little bit earlier about folks who are not out, right? And folks who maybe struggle with self-acceptance, right? Who have internalized a lot of hate, and have internalized a lot of discrimination in themselves. And I think we see that manifest itself in all sorts of different mental health concerns and issues, right? We know, and I think it is reflected in the statistics as well. We know that, rates of depression and anxiety are higher in GBQ men. And so I think mental health is another very large disparity or area of GBQ men's health. That's not sexual health. Related to mental health, I think, is also substance use. So often, used as a coping mechanism for all of this psychological stress and, a lot of trauma and discrimination that GBQ men face and have lived through in their lives. And I think the other thing is there is also a sexual community around substances as well. So oftentimes there are folks who have sex with substances. And, there's many different theoretical reasons and social theories around that. But, we know that substance use is more prevalent in this community than elsewhere. Also related to mental health is social isolation, right? Like if you're not out, if you're struggling with accepting yourself, it could lead to being very difficult to make social connections with other people, right? And that social isolation can last into older age as well. So we know and we see that older folks in the community often are socially isolated. They oftentimes they don't have a community around them that can support them. They lack those connections. Access to healthcare is another big issue. We talked a little bit about that at the beginning of the day as well. And then just, the everyday stress of discrimination, like minority stress, right? Like if every time you walk across the street and somebody yells something at you, right, that accumulates and that impacts your body in many different ways and your psyche in many different, and your spirit, right, in many different ways. And so I think these are all different things. And there's many, many more that are specific to GBQ men, that other populations don't face, but have led to health disparities that this population faces.
Yeah, absolutely. I mean, I think it is really important to acknowledge that. And then I think kind of like drawing out what you were speaking to earlier as well, just um, the system, the healthcare system, and how it's perpetuated the stigma that GBQ folks unfortunately faced. Because I think, the mental health care system hasn't always necessarily been the safest space. Like, a couple decades ago, homosexuality was like kind of seen as a mental illness, right, in the DSM. So, like, I think we have to really acknowledge that the healthcare system has not, been the most, I think, welcoming of these patients and has not like played necessarily a positive role in, building and helping them. So I guess like kind of adding on to that, like what are some, actionable ways that we can really help decrease the stigma and, help people build, that like mental health within themselves?
Yeah, that's a very big question.
Yeah,
I
for
think
sure.
I think the first thing is that people need to learn and unlearn, right? I think that the first thing is for folks to understand these issues, understand where they come from, understand, why this community experiences these things. And then I think it's also important as a first step is like an internal look into yourself, and making it like recognizing where it is that you contribute to that ongoing system, right? Like I think it's important for us to look and critically reflect, like, oh, do I believe in heterosexism? Like maybe not intentionally, right? But I have been brought up in the society where heterosexual people are the default. And so I need to look at myself and see where it is that I make that default for myself. Right. And then so once you recognize that, and I think heterosexism and recognizing that is just one example. I think there's many things to recognize. But once you recognize that, you can start to unlearn it, right? You can start to unlearn this default that society has given us, and that the society that we've all been raised in, right? And so I think once we recognize and unlearn that as the first step, then you can start thinking about, okay, what can I do next, right? What can I do to dismantle the system or untangle the system? What can I do to support GBTQ men's health, or other vulnerable or equity deserving populations, right? And those things I think will come only after you unlearn and after you can recognize those things. And it might become very simple things, right? Like might be something like speaking up in your everyday life when you notice something, right? Or you see something. And it might not, once you unlearn and recognize these things, hopefully you'll start to see that it's not just like um like obvious markers of oppression. Like it's not like that person yelling, something to this other person, right? It comes in more subtle forms that you'll start to recognize. And so it's calling that out. It's speaking out about that, right? And there's many other smaller actions that you can do. You can build, community. You can form relationships, with GBQ men and the community. And I think once you do that, the next step, the next action will become a little bit more obvious. And I think the action will look different for everyone, because I think everyone has different comfort levels in what they can challenge, right? But yeah, I think that first step is probably the most important one.
Yeah, I think I really love that kind of guiding principle of trying to, go on this journey of learning and unlearning. Because yeah, there is so much out there that I think, these paradigms in kind of day to day that we don't necessarily question much. And then kind of once just having that awareness, I think that can really serve as like the catalyst for more action. So thanks for sharing that. That's very, very insightful. I also wanted to talk about a little bit about intersectionality and how that affects this population. So can you also speak a bit to that as well?
Yeah, yeah. So, for folks who don't know or have never heard intersectionality as a term before, it's a concept that was coined by Kimberly Crenshaw, who is a Black feminist scholar. And essentially, it's a concept where you recognize that individuals can experience multiple experiences of oppression, multiple social locations, multiple different layers of oppression, but also privilege. So things like gender, like race, like socioeconomic status, and that these things all kind of intersect with one another. So it's gender informing a person's experience of race, right? It's sexuality informing a person's experience of gender. So it's a concept where we don't Like you don't look at gender alone in a silo. You don't look at race alone in a silo. I think it's a recognition that all of these things inform one another and impact one another. And so, for example, just as an example, the experience of a white gay man is going to be, and that person's experience of, let's say, sexual discrimination and oppression, that experience is going to be very different than someone who is a gay man of color, because the gay man of color's experience of queerness and of sexuality and of gender is going to be informed by their race, right? And the way that society looks at that person's race and gender, right, and sexuality. And so I think this is a really important concept to kind of name, because if we only say GBQ men or like GBQ trans men, non-binary folks, 2S LGBTQ folks, right? If we only say that alone, we live here in Canada in a society where white is the default, right? And so I think there is a danger in seeing these issues only from, say, like a white lens, right? Or the experience of how these folks who are white, their experiences, right? And then we won't consider how, for example, race impacts those experiences, and how the health experiences, right, and the health outcomes for this other population, like a queer person of color's experience of health and their challenges, right, are going to be very different. And so I think it's important that we have this kind of nuanced understanding of this community, because not all services that we provide are going to be applicable or useful for everyone in this community, right? And so we have to make sure that we have services for everyone.
Mm, yeah, I think, yeah, it's interesting because I think sometimes, we have these kind of almost like siloed services, and we, put everyone of, a certain, like everyone from, one, I guess, like marginalized population under one label, and then they're assigned to like this, so-called clinic. But every patient who walks through the door has, just like such a complex interfacing of all their different identities, whether that is their sexuality, race, gender, et cetera. And I think it is really important to recognize that, yeah, we have to understand, like, I think patients are, carrying a lot with them. And
Mhm.
as you said, like the default is this kind of, white cis male patient that we're treating in the healthcare system today. And the services are oriented to that population. But there is, there are so many more patients as well that I think deserve, the exact same level of care. So I really appreciate you bringing up the concept of intersectionality, because I think it is really important. I guess my last question, because I think, we tend to think about advocacy really from a clinical perspective, but I also wanted to hear your thoughts on how we can advocate for our patients beyond just the clinical setting, because I think that's what we tend to focus on as medical students. But, what are some other steps that we can take to advocate for our patients?
Yeah. So I think I would answer this very similarly to one of the last questions, which is, I think the first step is, again, to learn and unlearn.
Mhm.
And so that might be for your patient, like not necessarily understanding their clinical picture or their clinical, right, presentation. I think that's important, yes. But like then learning about that person's experience, that and the experiences of the communities that that patient belongs to, right? Like learning about queer history, learning about the different forms of oppression or different, traumatic experiences that this community experiences or is more prevalent in this community. Understanding and learning about like how we structurally have like a system where heterosexuals are the default, right? And how that flavors the life course of somebody who is GBQ or queer, trans, and that's coming to your clinic, right? And so I think that's the first step is learning and unlearning, because once you have that, full, or maybe not full, but like a more deeper grasp of who they are as a person and their experiences and their traumas and, everything that informs them as a human being, right? I think that is then how you figure out how to advocate for them. Um, yeah. And again, like I said earlier, like the advocacy or the action is going to look different from person to person, because everyone needs different things. But then if you want to advocate for a community as a whole, that might be volunteering, right? Like engaging with these community organizations, building community with them, learning about what those community issues are, and then using your voice where you can to support them. So yeah, again, I guess to summarize, again, I think it's that personal learning and that personal unlearning is so important, because I think that informs how, what you'll be able to identify and recognize when you do go to advocate for that person or that community.
Yeah, that's really insightful. I think, yeah, definitely like I'm gonna take that away with me from today's podcast, because yeah, there is just, I think, so much beyond just, the clinical medicine when we're treating these marginalized populations. So it's really important to actually get to know our patients and their communities and their histories. So thank
Mm-hmm.
you so much
Yeah. And
for
it's not,
sharing.
and maybe I'll just add that like I acknowledge that this is not easy work, right? Like learning and unlearning is hard work, right? And it can be uncomfortable work, right? When you're also looking at yourself and how you might be implicated in the system, right? And so I just want to acknowledge that and recognize that it is uncomfortable for many, many different people. But also maybe just a note that it is a privilege when you don't have to think about it, right? Like the privilege of somebody who is heterosexual is that they don't have to they don't have to experience the oppression. They don't have to feel the oppression. They don't have all of society, all of our services and institutions structured in a way that has not been built for us, right? And so a part of the privilege is not having to think about that, right? And so once folks start to encounter and like challenge that system of oppression or learn about it and unlearn about it, it's almost like you're challenging your own privilege.
Mm.
And so that can be very uncomfortable for people. But just an encouragement, I guess, for folks out there you do want genuinely, want to advocate for their patients and do want to have like a fulsome understanding of these communities. Like you have to work through that uncomfortness.
Mhm. Yeah, thanks for sharing that. I think that's certainly something that I think I can say personally. Like I think, I am starting to recognize my own privilege in a lot of the clinical encounters that I have with patients, and it is uncomfortable at first, but it is, work worthwhile doing, because I think very much like you said, at the end of the day, like these are, people's lived realities, their everydays, right? And it is such a privilege, like for a lot of healthcare professionals to be able to have the privilege to kind of, compartmentalize that. And I think it's really through approaching that discomfort, I think, as you said, head on, that we can actually truly like unlearn and learn, and then, focus on the next steps. So
Mm-hmm.
yeah, thank you. Thank you so much for all your insights today.
Thanks for tuning in to Just Medicine.